And for those of y'all that are new to the town hall, many of y'all have probably seen or even done this before, but we do have a little survey that asks about not only what possible capacity you might have for syphilis testing and treatment for those organizations that are in the field, but also a little space to give us some feedback about what you'd like to see in our response efforts. And I might give this another 60 seconds to let the audience trickle in, and we'll get the real show going. Okay, so in the interest of everyone's time, I'm going to get this ball rolling. I want to make sure we give Dr. Roche the floor as much as possible. So this is our 5th syphilis outbreak response town hall, and thank you guys very much for making time for this. And like I said, for those that haven't already, we do have a little survey, and my partner in crime over there will drop that link into the chat to make it easy. And just a quick reminder, this is an informational call, not intended for media purposes, but if we have anyone out there that is interested in contacting our media department, we've got a link for that as well. And we'll drop that in the chat. And while I'm thinking about it, we'll also make these slides available to everyone shortly after this meeting today. These next 2 slides I'm briefly going to touch on for a couple reasons, but I always include them for anyone that's new to the efforts. But these are the 6 components of our syphilis outbreak response. And this slide, don't bother digesting it all, goes into a little more of what those activities look like under our enhanced surveillance, our enhanced clinical operation, our public health follow-up, outreach, etc. Public information is exactly what it sounds like, and this very last one here is community mobilization, and that is the area that I am co-leading. The reason we're not going to go into it too much here is we're going to turn it over to folks that can speak to you about what this looks like in application, the leads to each of these teams. And with that, and Chelsea, I'm not sure if you made it on. We've been bouncing from meeting to meeting today. But I'm prepared to go over these if not. These have been a coveted resource in the community, and we just updated them last week. We're doing it once a quarter, but these are what we call our hotspot maps. So these are all stages of syphilis, primary, secondary, early, and late latent. The one you're looking at here, so this is for 2022 to 2024, and this includes both male and female, and all ethnicities, all age groups, etc. The lighter spots are where you see the greatest density. So downtown Montrose area, southwest, right along the Beltway, and then up north and down south, you see those red spots as well. What this has allowed us to do is, if we can make sure we're on mute, guys. This not only informs our efforts, but it helps us inform our partners of where to best direct their resources. This next one's going to look very, very similar. It is the breakdown. This is just male sex at birth. You'll see the very, very similar pattern. Obviously, it's a little less dense, but you got that spot in the center, downtown Montrose area, 002 and 006 zip codes, southwest, and then south and up north. Where we see a divergence is when we come over here and look at, again, this is, and I realize I forgot to update the header up here, but this is 2022 to 2024 female at birth. And this is where we see a shift. So we still have some of the same spots up north, southwest, but that really concentrated part, downtown Montrose area, we shift to this new, brighter, denser spot down south along the loop. And not only will you get these slides, but we'll also get these heat maps up on our website, our syphilis page of the HHD site, so everyone will have access to them. That may take me a couple days. And with that, I'm looking to see if Miss Maria Hernandez has been able to make it over from her meeting. You ready to take over, Maria?
Yes, good afternoon. So currently in the disease investigation team, we have about 12 DIS, including support staff and FLSs and leads that give directives and guidance to the DIS that are doing conducting public health follow-up on patients to either bring them in for treatment or conduct partner elicitation to decrease the spread and intervene within our Houston Harris County community. We also have 15 surveillance staff that make these assignments as labs are coming directly into our theses data system, or fax requests or mailed fax or mailed labs. We currently monitor all our activities through, we used to monitor all our activities through spreadsheets, and now we're only managing all our activities that the disease investigation team does through RedCap to monitor all the investigations so that we can have better data and assist our community. We currently in SOR have had a total of 3,550 actionable field records or investigations. In the next slide, we see the number of clients. Can you go to the next slide, Eli? On our next slide, you can see the referrals that the DIS make to our City of Houston clinics. Of course, we also refer them back to their provider if that's something of their choice. Sometimes providers do not have the biostimulant due to the shortage. We do have certain criteria for those patients that can receive biostimulant because of the shortage. But we do make appointments for them so that they can come in and get evaluated and treated. And that is what the disease investigation team does. Thank you.
Maria, thank you so very much. And I'm looking to see if Ms. Jeanette's been able to hop on, because I know we have been juggling the meetings today.
Hi.
Oh, hi there.
Hi. Good afternoon. Hi. So the updates on their clinical operations under the community provider partnership, we have met with more than 200 providers from 55 different healthcare facilities. We have presented at more than 30 events, reaching over more than or around 1,200 MDs, NPs, and also other clinical staff. And we have received over 700 provider calls to the syphilis hotline. This syphilis hotline, it's a good resource because providers are actually allowed to call us, and we can actually help them to get the medical history regarding syphilis and treatment adequacy, et cetera, to help them understand how they would proceed with their patients as well. This provider visit actually and communication and partnership with them, it's a strategy as a result of no confirmatory tests using FDA ABS, or maybe also inadequate stages, diagnosis and treatment, or not reporting. Also under the health centers and pharmacy, there's a streamlined clinical treatment process. Also, they have implemented daily medication report, and they has been expanding the treatment and administration capacity for syphilis. Also having implemented a medication inventory process. And under the call center actually it's following up patients that has been prescribed doxycycline in our clinics, and they basically are making sure that these patients are being adherent to the treatment. Thank you.
Yeah, and I kind of snuck this slide in on Jeanette, but we wanted to give a little bit of a visual on what our treatment administered has looked like over the last couple months. And so you'll see that lighter blue is the doxy that we're having to rely on. Orange is 1 dose of bicillin, dark blue is 2 doses of bicillin. And we are reserving those for pregnant individuals and those that are housing insecured. And Miss Guadalupe, I'll turn it over to you.
Thank you, Eli. Hello, good afternoon. So for outreach and education, our efforts continue to raise awareness, provide education, and promote prevention and testing among vulnerable populations. Our outreach strategies include targeted outreach to high-risk groups and communities. So through the surveillance data, patient interviews, active cases, we identify and reach out to vulnerable communities with increased risk of syphilis transmission. Such communities include men who have sex with men, the unhoused, substance users, sex workers, women of childbearing age. We distribute educational materials, condoms, and information about testing services at locations that are frequented by these groups. Also, our mobile testing services. So we deploy mobile testing services to underserved areas or locations with high syphilis prevalence to offer convenient and confidential testing services. We continue our syndemic approaches. So when out in community, we are not just offering syphilis testing, but we offer bundle testing that includes syphilis, HIV, and hepatitis C. So on site, when we conduct these screening events, the results are available for the community members. So we have a stat lab on site. We also have staff that has the capacity to do the record search on site. So whenever we get those titers at the event, we have a staff that is able to go into the system to see if they have history, to be able to identify if in fact this is a new case of syphilis, depending on their titer and what history they have.
And it doesn't stop.
I'm sorry?
Yeah.
Oh, okay. We also have DIS
got
on
it.
site to conduct interviews.
Hello. How you doing?
Okay.
I think you're good, Guadalupe.
Thanks. Okay. We also have a service linkage worker on site in the event that we have a new HIV so that they're able to begin the intake process and link them to services. We've also had a PrEP navigator to provide education and referral to PrEP services, as well as our vaccine services. We have also had the opportunity to provide transportation services to those individuals who are needing it that test positive for syphilis. So we transport them to one of our STD clinics. DIS then closely follow up with them. So the implementation of these strategies have all been in efforts to help contain the spread of syphilis, definitely to reduce stigma that's associated with STIs, and improve access to testing and treatment services within the affected communities. And this slide shows the events by services offered. So depending on the need, the capacity and the venue, the testing of the site, some events we only have the capacity to provide education. Others we bring out education and testing and education, testing, vaccine services. Again, it just depends after we assess where the site's going to take place, what are their needs. That's when we determine the type of services offered. But of course, we always want to bring as many services out. And then the tests done. Again, the bundle testing, which is the syphilis, HIV, and Hep C. We've had the opportunity to also with our HIV prevention subrecipients when the ones that have the capacity to offer chlamydia and gonorrhea testing.
Guadalupe, thank you so very much. And this last slide before I turn it over to the wonderful Dr. Roche, this is what I'm in charge of, and a perfect example of what I do is what you see today. And so while Guadalupe and her team are focused on getting direct to the community, getting those services directly out there, my focus has been on reaching out to the agencies and networking resources, trying to mobilize that exchange, making sure we're leveraging their networks and helping them to access what they need to coordinate the best response we can, given the situation we are in with the bicillin shortage, et cetera. So to date, we've done over 60 mobilization events. Like I said, this is our 5th town hall. After today, we'll be at 1,000 community partners, thanks to y'all showing out, about 30,000 pieces of collateral. And I do want to do a little plug here, and my colleague will drop the link in the chat. We've got a webpage we are very, very proud of, and there's a link on that webpage to, if you want to have something similar to this, a Syphilis 101 presentation for your organization, we are still doing those. And without further ado, of course I went too far there. Let me get back, but I'm going to stop screen sharing and turn it over to the wonderful Dr. Roche.
All righty, here we go. Let's see. All right, everyone should be able to see this screen. I hope it worked for Eli before, so hopefully it works for everyone here. All right, so thank you all. I hope that you all find this talk valuable. And to be honest, I go through what I really want to get to, time permitting, is a series of cases at the end of the talk that everyone will have the opportunity to weigh in on, because I think it paints an interesting picture as to what the pediatric infectious disease doctor deals with on a day-to-day basis. I've got no disclosures to report, but I will say that I do run a clinic here at Texas Children's that's focused solely on congenital syphilis, and that is it. And this is fielding questions, fielding patients, making sure that these kids get the follow-up that is recommended by the CDC and by the Red Book in their evaluation. And so I will say that for this first part, anyone who's watching on a computer, you can even do this if you're watching on, or if you're viewing this on a phone, you just have to do a screenshot. But here is a QR code that you can scan. And it's going to ask you need to register to get credit. No, you don't. Just hit skip. It'll be done as a guest. Does not really matter. But if you're having trouble scanning, you can actually go to polev.com and go to Ryan Roche. There are not that many of me. And so the purpose of this is to allow everyone to interact later on at the end of the session. And this QR code will pop up later as well. But as a test, the question is to see how many people this is actually working for. So I'll say, in general, if it's working for 6, 7, 8, it's probably going to work for most people. And so while we can allow this to tick up, it's really more important in probably about the next 30, 40 minutes when we get to the cases. So good to see that it is working for people, but that'll take us to the first question, which is, who was the U.S. president the last time syphilis cases were as high as they are now? So curious to see what people would weigh in on. Let's see. And there is an answer to this question. Now, it is always curious to see, do people look and go, oh, someone said Clinton, I bet it's Clinton, and jump around. But this is why it's good that it's anonymous, because no one will know what your answer is. So it looks like it's a toss-up between Clinton and Truman, and now Truman's moving into the lead. I feel like I'm announcing a horse race. And the real answer is the Truman administration, and actually got to the Truman administration level back in 2021. It's only gotten worse since. And while I will say that the number of cases reached the highest since the rate was the highest since 1991, it was actually a total number of cases hit its highest since 1948. And honestly, it's only gotten worse since. And as a result of this, you see that the CDC is consistently updating all of their nice infographics that are available on their website. But I do want to point out here that And I'm not saying that other STIs are not important, but I do think it's important to note that cases of chlamydia were actually down from 2018, and gonorrhea only up 11%. But if you look at syphilis, up 80% from 2018, and congenital syphilis up 183% since 2018. And to put these numbers into perspective, which I'll have in a little bit, back in 2012, there were right around 300 cases in the United States, and in about 10 years, we've almost gone up to 10 times that. So one reason why this is a problem is when you look at primary and secondary syphilis across the United States. 2013 is shown there on the left, 2022 on the right. You can see that most of the United States has become this nice deep violet or purple color. And what that's highlighting is that almost all of these states have moved in the wrong direction since 2013. The reason why I say primary and secondary syphilis, which is, and this is in the adult population, or individuals age 15 through 44, the reason why I make that important distinction is when you look at the number of congenital syphilis cases as a function of primary and secondary syphilis, you'll see that as primary and secondary syphilis rates go up, so do congenital syphilis cases. And so this is why a lot of people are working to try to treat during pregnancy individuals who have syphilis, that you can reduce the rate of congenital syphilis. I will highlight, though, that a lot of people take this to mean, well, if I treat you during pregnancy, your child will not have congenital syphilis. And while that is a hope, I hope to show people later that it is just that it reduces the risk. It does not 100% remove it. The reason why, and I mean, why to care about congenital syphilis, there are other reasons, but if you look here and you can see that the number of stillbirths and infant deaths is also creeping up at the same rate, and I put this slide in here, a lot of people say, well, it's only going up because we're testing for it more. If that were the case, you would expect to see the number of stillbirths and infant deaths also plateauing out, and it is not, suggesting that the signal is truly real. So, next question. What states lead the way? So I showed you that 2022 map. You can see there that it was pretty much violet all over. But what states lead the way in congenital syphilis cases? And we'll see if people hop back over to their devices quickly to answer this. DC, California, Texas, Mississippi, kind of sticking down around that purple belt. And yep, this all looks pretty good. And what I will say is the reason why I'm framing it in this way is because I think it's important to discuss the congenital syphilis cases and congenital syphilis case rate. Ryan Roche, he's leading talking about it, but I'm not sure if he's leading the way in the cases. So hold on, next slide here. And so, yeah, a lot of people threw in Texas. You can see here, CNN article 2023, increasing in Houston. See Forbes, increasing in Houston. Houston Health Department launching a rapid outbreak. Houston Chronicle, Texas leads the nation. There are New York Times articles about Houston. Houston is in the news. And I say, somewhat tongue-in-cheek, that we are a leader in the field. And that is for two reasons. And so, yes, Texas leads the way with cases. You can see here what I've shown in the table is actually the 2021 numbers. You'll see as I click through to the next one, you can see that Texas went from 680 to 922. What I do want to highlight, though, is that in 2021, we had about 182 per 100,000 live births. It's quite a few. Fast forward, in 2022, that number went up to nearly 250. The reason I make this point is because the number of cases is a function of the case rate times the number of births that you have. So you look at a place like New Mexico, who had 13 times fewer cases as Texas, but if you notice, their case rate is not quite double what ours is. About 100. It's about 1 3/4 times higher than what our rate is. And so this is important to see that it's not just the rate, it's also the rate times the number of live births. And so no one should really be surprised. Florida has a huge birth rate. Absolutely. California, Texas. This is why we're leading the way in cases. And this is a multidimensional problem of regional, racial, ethnic differences. But I think that this graph shown here on the right by the CDC really does a good job of showing racial and ethnicity differences. On the left, you can see the percentage of live births in America in 2022, and on the right, the percentage of congenital syphilis cases. So you can see for white or Caucasian, you can see that while they were 52.2% of live births in 2022, they only accounted for 27.5% of the cases of congenital syphilis. And you can see different live birth rates crossing over. You can see that same downtrend was seen with those who are Asian. But what I sometimes goes unmentioned a lot of times when we're talking about those who are most affected is actually the American natives and the Alaskan natives as well, where you see very significant, only 0.7% of all live births for those individuals, but nearly 5% of all congenital syphilis cases. So a lot of problems. But I put up this slide from the CDC, a graph to say we have found success in the past. You look back here in this precipitous decline right after 1941 was with the introduction of penicillin. And we found success in the past. And so what is going on that's different now? And this is where I get into the historical aspects of this infection, which I think are interesting. And it may seem a little bizarre, but I promise you that these conversations come up with the families that I see in clinic, and it really does. And I personally say that I do believe that it does help give perspective for those families, and it really does make for an engaging conversation with them, at least when I'm seeing them in clinic. So Maya Angelou said, you can't really know where you're going until you know where you've been. So where have we been? Syphilis was actually first described back in the late 15th century, and it was described by Italian physicians who, after being invaded by France, essentially said they brought with something more terrible or disgusting has never been known on this earth. And the Italian physicians actually called it the French evil. And, at the time, people said, well, let's call it cruel pestilence. But really, the name of the disease that stuck was the disease of the French. And the disease of the French was how syphilis was largely known throughout the world. However, that was only in certain parts of the world. In Poland, they called it the German disease. Russia, the Polish, Portugal, Castilian disease, India, the Portuguese evil, Japan, Chinese ulcer. You can see here, and I do bring this up in clinic. Most people come in and I say, what do you know about syphilis? And they point at their partner and they say, well, I got it from them. And I'm like, yeah, it's sort of what Russia did. It's sort of what Turkey did as well. But syphilis, we're calling it syphilis or testing for syphilis. That term actually originated in 1530. And it was a name that was given by an Italian physician who wrote a poem called Syphilis or the French Disease. And in it, he described a shepherd who upset a god, and the god racked the shepherd with the sores of syphilis, and then the disease took the name of the shepherd, whose name was Syphilis. And so that's where syphilis, the name, actually comes from. And it's interesting, though, that the disease of the French stuck around for quite some time. And then really by the mid-19th century, syphilis is what physicians were calling it. The problem with it is everyone knew that syphilis was a venereal disease. And so people wouldn't say syphilis because it implied sort of, more questions of morality. And so this is where you start to see the term luz or luz venerea coming in, among others, writing about the disease, because you couldn't say the word syphilis. And people will look and say, well, yeah, but to be honest, this was the 1800s, Ryan. True, but actually in New York in the 1940s, there was an attempt to have a bill that was proposed to combat syphilis, and there was a huge to-do over the fact that even including the word syphilis would, quote, corrupt innocents or children and create a shudder in every decent woman or man if this were in the bill. And so this idea of trying to talk about charged or stigmatized language existed even in the 20th century. And so the reason why I make that distinction is whenever I see patients, I see most of my patients are newborns. They don't really talk that much, but the family members, I come and I ask them, what brought them here. And a lot of them are sometimes a little reluctant to say syphilis. They know what it is, but they don't want to say it because of a stigma associated with it. I found it interesting that this idea of not discussing something does date back even into the mid-19th century, when a physician at the time commented that the whole of society must unite its efforts to wipe it out. But practitioners have been reduced to disguising the thing behind euphemisms euphemistic circumlocutions, and which is a very large word to essentially say people disguise behind other terms. They will not call it what it is. Syphilis, that's what it is. It's an STI. And I've had families say, well, my provider told me that I had an infection, or because I had an infection that my baby needed to be treated for that. What infection? And a lot of times they just don't know the answer. So one of the original solutions came from Alfred Fournier, who started one of the first international conferences on the prevention of syphilis. And the reason why I mention his name here is that one of the things that he discussed in these conferences is this idea that you need to have outpatient clinics that are numerous, free, open access, open at hours, which allow the worker to visit them without prejudice to his job or his purse. And I say that because this is someone who is writing about this about 130 years ago, but still picking up on the fact that if you're going to be successful, you can't give someone a prescription for Bicillin, tell them to go fill it, at the Walgreens and expect that they're just going to shell out $500-$600 to get something done. That's not going to happen. But also we can't expect them to show up at an outpatient clinic that's open from 11 o'clock until 2 p.m. because, how is that going to affect or prejudice them towards their job? Now, historically, we've talking a little bit about the fact that, there's not Bicillin, at least the word, I don't know if I'd say it's the word on the street, but from what I have heard is that some of these thoughts about concerns for Bicillin should be disappearing by Q3 of 2024 as production is being ramped up. And so while we have therapeutic problems in that we cannot get Bicillin, in the past, really all you had was mercury. I kid you not. And mercury stuck around really honestly until the late 1800s, early 1900s as a potential treatment for syphilis. Problem is that, as people can imagine, it made you horrifically ill and sick. But another one I bring up is guaiacum. And so guaiacum is a tree, and so it's a sap from the root of a tree. And individuals would actually chew on the sap from this tree, which is where the term gumma actually comes from, because they would chew on it. It was like a gum, and you'll hear whenever you read old literature, people talk about, and he was taken to the root or taken to the bark. And so it's actually a mention of chewing on the sap or the wood of this tree. But the true first treatment that was identified, which won the Nobel in 1908, was arsphenamine. It was compound 606. And so this was a tincture of water-soluble arsenic that individuals would inject in their veins every week for 40 to 52 weeks. It was actually first used for syphilis in 1909, but to give you an idea of the therapies we used to have, one that won the Nobel in 1927 was malaria. So it was, you would give people malaria because malaria appeared to cause fevers that were high enough that it would actually treat people of their syphilis. But we had a treatment for malaria, so give them malaria, wait, that would treat the syphilis, then treat them with quinine, and then you've solved it. And that got the Nobel in 1927. We also had issues with trying to get the word out. And so if you imagine back in the early 1900s, the majority of the population did not read. Spoken word language was how people had communicated. In fact, actually in the early 1900s, like really early 1900s and late 1800s, was a big push to say, look, people should not be reading because that's going to get in the way of work. We don't need people reading. We need people working. They don't need to read to work. And so there was a big push to try to get the word out about syphilis to people. And so, French playwrights wrote a play called Les Aviaries, which was essentially about individuals affected by syphilis. And while it seemed from the critics to be okay when this was across the pond in London, when it made it over here to New York and it was shown in front of viewers, the reviews from the New York Times were a little less welcoming. And one of them came out, and these are clippings from the New York Times back in 1913. It said, "It tries to treat seriously of subjects generally considered too delicate for common conversation. It may accomplish some good, but invariably causes harm by its appeal to curious and morbid minds." And so when you think about what we try to do for advocacy, you can't get out and just tweet about this back in the 1900s. And people were trying to get the word out, but again, had trouble doing so because people were trying to stifle that attempt. And you cannot talk about syphilis without talking about the Tuskegee study. And I bring this up because it's not that I've had one, two. I've had a handful of families who've shown up and seen me in clinic and actually questioned me about, well, you're doing all this stuff, but how is this any different than what was done at Tuskegee? And I think this is really important to consider, particularly when we're talking about the fact that we have penicillin and we have bicillin. These are the best treatments. And now we're saying, okay, yeah, but we're not going to give you that treatment. We're going to give you this different treatment. We think that this different treatment works, but we don't have. So this has come up a couple of times. So I think it's important to understand that these undercurrents exist within the population. I think we'd all be well served to read a little bit more about it so we can answer those questions whenever we're prompted by families. Now, there was a turning point. You look back at that graph from the CDC in the 40s, boom, just a huge drop in the number of cases. And I bring this up because, in the first couple of slides before I got started, this idea about stigma, about immorality. And initially, a lot of this was because, well, it's the people don't want to learn about it. But Paul O'Leary, who was a syphilologist in the 1930s and 1940s, made a point in this book that he wrote a foreword for called Corky the Killer. It was it was a 1940s graphic novel about syphilis. I actually have a copy of it. It's pretty interesting, but commented that secrecy of the disease had been due in great measure to conservatism of the medical profession as well as press in publicizing data, and not to do with the fact that the public didn't want to know much about it. And I say that because people are like, oh, now that we're talking about it, now that we're talking about it, that's why the disease has come down. And people say, yeah, but penicillin really helped decrease the rates of this disease. But I will point out that actually in the United States, we weren't tracking this really until the early 1940s, but in the UK, they'd actually been tracking this in the very early 1900s and late 1800s. And what they did was they noticed that in the UK, there was a pretty high rate of death due to congenital syphilis. There were no treatments. But then all of a sudden, you can see here, it's on this leftmost graph, it's these dotted lines. Right here with this first red dotted line, you see a significant decline in the death rate. And what that was that actually coincided exactly with the passage of the Venereal Disease Act in the UK, which essentially centralized treatment of these individuals. And it said that it prevented the treatment of venereal disease other than by duly qualified medical practitioners. So this is why I say I think, language is important. And solely by controlling and having a consolidated statement toward the venereal disease, they're able to see a significant decline in the death rate due to congenital syphilis. So, congenital syphilis, what does it look like? The term that often gets attributed to William Osler is that syphilis is the great mimicker, the great imitator, but he never said that. And people said that that's what he said, but really what he said was no syphilis in all its manifestations and relations, and all other things clinical will be added unto you. And the reason for that is because it can and will look like anything. So that makes it hard for people who come in, oh, all I had was a rash, could be syphilis. All I had was a stuffy nose, could be syphilis. All I had was a headache, could be syphilis. The problem is it can look like anything. And the only way in which you're going to know if it is truly syphilis is by testing and evaluating and following up. So congenital syphilis, what I am talking about, can occur during any stage of syphilis and during any trimester of pregnancy. I hear this a lot because people say, oh, mom just had latent untreated syphilis. I've got nothing to worry about. Incorrect. Oh, mom was infected and treated, in the second trimester. I've got nothing to worry about. Incorrect. It's good she got treated, but it does not relieve you of having the risk of still having congenital syphilis. And so finally, while intrauterine infection can result in stillbirth, high drops, preterm birth, the majority of individuals are asymptomatic at birth. Finally, congenital syphilis is classified as either early or late disease. And to be honest, the majority of cases that are seen now, because we are a little bit more aggressive about treating, are early congenital syphilis cases. Early is defined as occurring in infants younger than 2 years of age. And the most common findings that I've listed here go with the recommendations of what testing is. Hepatosplenomegaly is very common, but it's very nonspecific. Kids can have all kinds of reasons to have a large liver. But this is why we send a liver panel. Bone involvement is the most common specific manifestation. So if you see metaphyseal lucencies, periosteitis, this is very classic of congenital syphilis. This is why we do long bone films. Skin and bullous lesions. It's why in the past we used to do dark fields. We don't really do that anymore. But meningitis, lymphadenopathy. It's why we do a lumbar puncture. It's why we do a hearing screen. Thrombocytopenia. It's why we do a complete blood cell count. And then pneumonia or pseudoparalysis. This is why we do chest x-rays or long bone films. So these manifestations that can be seen but aren't specific are why we do the workup that we do. And here are just a few images from the Red Book showing individuals who have had congenital syphilis confirmed. You can see this peeling desquamative rash on the feet. That is a rash of congenital syphilis, but so is this little lesion on the upper right-hand corner. Bottom right-hand corner is someone who's marked out the size of a liver on a baby, and then jaundice as well is another common finding, can have an elevated direct bilirubinemia. What you don't see in this picture as well is that the baby has a little bit of congestion in this upper left-hand most picture. And so these are common findings, but here's the hard part. A lot of people, they deliver a baby, you'll probably see this rash on the feet, but how many babies also don't come out with their liver margins marked, but how many people are really, truly feeling for liver margins? That's what you would hope, but how often is it happening? I don't know. Now, late congenital syphilis, I put this out there just to show what happens when you miss this and these kids go undiagnosed and untreated. You actually have bony lesions, and you can have invasion of the eye, you can have perforation of the roof of the mouth, and you can have dental abnormalities. And this is what they will look like: hard palate perforation, keratitis in an individual with late ocular syphilis, and then Hutchinson's teeth. These are the sort of diamond or pointy shaped incisors that can see. And this is with late congenital syphilis when it has been missed and not treated. Not you were treated and then in time this manifests. This is you were not treated. So testing, this is very difficult, and I'll tell you why it's a little difficult in a couple of slides, but it really boils down to serologic testing, and there are two choices: your non-treponemal and your treponemal. The non-treponemal is called that because Treponema pallidum, is the infectious agent that causes syphilis. And so non-treponemal is looking for something that occurs in our body as a serologic response to infection. And the two typical ones are a VDRL or an RPR. And RPR stands for rapid plasma reagent. These tests are sensitive, but they're not specific. Then you have your treponemal tests. And this is where it gets really confusing, because I get a lot of referrals from people who say, oh, they had a positive treponemal test. Well, which one? Was it a T. pallidum chemiluminescent assay? Was it a T. pallidum enzyme immune assay? Is it a particle agglutination? And what I've seen not infrequently is a lot of people say, oh, it was a TPPA, which is the recommended confirmatory test for syphilis. But people say, oh yeah, no, we got the TPPA back within 2 hours. No, you did not. And what is happening is a lot of people are seeing treponemal test, and what they're reporting is they're reporting a TPEIA and then saying, oh, that's a TPPA. It's not. And so this happens not infrequently, and it causes a lot of confusion. And if it's causing confusion for providers, what do you think confusion is having for the families as well? While we all love PCR, there is no FDA-approved test. There are a lot of laboratory-specific testing that is done, but these have not made it into mainstream, at least as of yet. So the reason why diagnosis and timing are so intimately related is because you can miss primary syphilis if you have no repeat testing. So here's a graph that has been around for quite some time, and I always point people to the y-axis and the x-axis. And the reason why I put this in there is because if someone gets infected, time post-infection, we'll say, is 8 weeks. If you go to 8 weeks and you go up to your non-treponemal and treponemal test, right here, percent of patients who test positive after getting infected is about 50%. So that a way to interpret this is if an individual gets infected, has it, and they show up at their 8-week prenatal appointment and you test them and it's negative, that means that they're not positive. That's good, but it does not mean that they will always forever remain negative, because it can take some time. And this is why Texas law mandates that pregnant women are screened, or that women are screened multiple times throughout pregnancy, first visit, third trimester, and at delivery. I'll also point out what is interesting about this test as well is that people say, oh man, it's good that we screened mom with an RPR and it was negative. That's really good because that means she doesn't have syphilis. Not necessarily. And so with the non-treponemal testing, RPR, what you see is around 2 to 3 years post-infection, as many as 40 to 50% of people can serorevert, which means they have, if you screen them with an RPR, they will screen negative, but it does not mean that they never had syphilis or were never treated. And this is why it is so confusing. Now, another one is the RPR that we use a lot, right? We do an RPR at birth, test at birth. If that RPR is negative, it's going to be okay. Not necessarily. It can actually be falsely negative in overwhelming infection, and this is called the prozone phenomenon. And this has shown up, and I get called about this quite frequently. I've been called about it oh, sorry. I've had a few calls about this recently in some other states, and have had one case of this here locally that I've noticed. And this is why you'll see some people saying, this is why you shouldn't do an RPR. It's why you should do a TPEIA, back and forth. But it's just to point out that whenever you see a negative RPR, that's very reassuring. But if you have other findings consistent with syphilis, you cannot rely entirely upon just an RPR. So the reason why we have all these problems is because testing is no more than about 120 years old. But what I want to point out is that while the original tests were with dark field microscopy, it was dark field where you're taking a lesion and looking at this. Well, that was the original test. The first true serologic test was developed in 1906 by Wasserman. It was called the Wasserman test. And what Wasserman found in the patients of individuals with syphilis was reagin. And so when someone realized that the Wasserman test took a little too long to come back positive, they wanted to make a rapid plasma reagent. And so that's what they did. And that's where the term rapid plasma reagent, RPR, comes from. What I tell anyone who wants to listen is when you send an RPR for syphilis, this thing we're trying to get way ahead of, that test is about 70 years old. And then the treponemal test, like these great tests, oh, we just need to send the treponemal test. That's the true one that's going to tell us. Most of the treponemal tests are about 60 years old, 50 to 60 years old. So what's changed? Not much. Things are in the pipeline to be developed, but they have not been tested or tried and true like some of these other tests that we have. So whenever you're evaluating a newborn, I say pick your poison. There are a lot of choices. You can go to the CDC. You can go to the Red Book. In fact, Baylor has their own guidelines that other hospitals have had for acute care of the newborn. And within it, you see algorithms that walk you through how to evaluate a child for congenital syphilis. And they largely parallel each other with some what I would call is interesting semantic differences, which one that I found that's been rather interesting is that in some of the guidelines they say that there's evidence of reinfection, and then other ones say that there's concern. So the Red Book says maternal evidence or concern of reinfection. The reason I bring this up is because if you have an individual who is with a partner and that partner was never treated for syphilis, I'd argue that maybe there's concern for reinfection, but other people say, well, no, it's only if there's evidence. And what evidence is versus concern, probably argue it till the cows come home. But these interesting language differences in the hands of providers then become discussions and conversations. But the algorithm is quite prescriptive, and it does lead to a lot of questions. However, when you get on the guideline, which means, do you have a history of syphilis in the past? When you get down to the bottom, the Red Book guidelines, the CDC guidelines, they never say, oh, no, you don't have syphilis. It's either proven or highly probable, possible, less likely, or unlikely. And I bring this up because so often I hear from a lot of families who come in and they're like, oh, I was told that my child absolutely had it. I was like, it's possible. Actually, it's possible. And then I get a lot from families like, no, I was told that they do not have it. I said, that's the problem. We do not have good diagnostic tests because this is serologic. And because it's serologic, if you look in the baby, you will find true evidence that they have infection, but is it mom's serologic testing that's causing us to be positive? One of the most common fallacies that I see in calls that I get in individuals who are sent to me, one of them is this claim that mothers are serofast. Serofast is treatment before pregnancy with low stable titers. So I'll have individuals who will come in and these individuals will say, oh, hey, I've got a RPR came down to be 1 to 2. And because it's 1 to 2, as a result of this, what I have is I have serofast. And that's actually not the case, because if they were treated in pregnancy and they were 1 to 2, that's not serofast. So I see this a lot. And the reason why that's important is because that claim that they're serofast moves them down to a lower likelihood category. But if you say maternal treatment during pregnancy and more than 4 weeks before, you end up with this possibility of being into the, you end up with being in this realm of possible or proven or highly probable. So the next one is what defines adequate when speaking of maternal treatment. So that's the next one that comes up. So I bring this up because a lot of times we'll say, oh, did mom get her dose of penicillin? Did mom get her 3 doses of penicillin? How much did her titers come down? And a lot of times people are like, oh, well, mom got treated during pregnancy and her titers went from 1 to 32 to 1 to 16. So she was treated. But I would argue, did you actually get treated appropriately? Perhaps you got appropriately, but did you respond as you would expect that you would? And so for this, what you'll see is the adequate therapy. Adequate therapy is defined as, did you get the right amount? But in this paper, they showed that 88% of participants had a greater than 4-fold decline at 3 months after treatment. 80% had an 8-fold decline at 6 months. So what that means is that 80% of people, if they came in at 1 to 64, 6 months after treatment, should have gone down to 1 to 8. And so it's this whole idea that you should expect to see some serologic response when you should expect to see some serologic response. And consider this in the setting of pregnancy and screening and treatment, because if you're treating at 8 weeks, wouldn't you expect for those numbers to come down? So yeah, simple management here. Simple management, if it's proven or highly probable, you do a full evaluation, you do 10 days of penicillin. Possible, you do a full evaluation, you do penicillin or bicillin in normal infants. And then for congenital syphilis, less likely, you don't have to do an evaluation. And this is doing the lumbar punctures, doing the lumbar puncture, doing the x-ray, doing this. And ultimately, if these kids have, most are recommended to get a shot of bicillin. But if you don't want to give bicillin, some people say follow them up. And if you follow them up, and then it turns positive, give them bicillin. I will caution people in this follow-up scenario that when I look at, there was a paper at PAS recently, and what they found in PAS in this group was that they had about a 47% no-show or loss to follow-up rate. And I see the same thing close in my clinic. It's not that they don't follow up, but they do not show up for that first visit, and then I need to see them again and try to reschedule. But this does require quite a bit of effort, and so it doesn't just naturally happen. So for this next part, I have cases. Don't worry about scanning this. I just put this in that there are guidelines, and if people are negotiating and playing with the cases and doing this, maybe it's hard to get onto the guidelines. But here's the first case, and for anyone who wasn't on there before, go ahead and you can scan this QR code again. So this case, mother was late to prenatal care at 22 weeks. The RPR was 1 to 512 at the first visit. She was treated for syphilis, treated with bicillin 3 times during pregnancy, and when she showed up, her RPR had come down to 1 to 16. However, the OB who was following her had reported that there were congenital abnormalities, an echogenic bowel, and some hepatic calcifications. When the baby was born, in the records, people said, oh, the RPR is 1 to 8. The examination had a large liver, failed a hearing screen, and had hepatic calcifications. So the first question is, what do you want to do next for this patient? Mom was treated well before delivery. Her titers came way down. The kid's titer is less than mom's titer. The kid has a large liver, and the kid also failed a hearing screen. So what would people want to do with this patient? Okay, so it looks here like people are saying retest, follow up with other tests, treat the newborn, treat test, restart mom, and okay, treat and highly probable. Okay, thank you all. And people are weighing in, which is great. And I'll make sure to try to make this QR code a little bit larger so people can weigh in here as well, begin treatment. And so, this next one here is, so then what is the probability? And this gets a little bit at what people were getting to in that last section, which is, is this proven, highly probable, possible? And it looks like everyone is going towards both of these, and that's good. I could see that some people might push back and say, well, I can't really tell you is it proven or highly probable because, we haven't done an evaluation, right? I just told you about the physical examination. The reality of it is it's a little bit different than that. And the reason why it's a little bit different, here, let me go back. The reason why it's a little bit different than that is because in this kid with a physical exam that is consistent with congenital syphilis, that is immediately proven or highly probable congenital syphilis. The large liver, the failed hearing screen moves you straight there. So the reason I bring that up is we say, well, do an evaluation, right? People said, well, do this evaluation, do the lumbar puncture, do all these things. But is it going to change that likelihood? And so I like to see people saying yes. And this is a point of contention because this is what's come up recently in the new CDC guidelines, which is tapping the kid may not change anything. It really may not change anything. And so as a result of that, will it change it? And a lot of people would say no. The evaluation would. The examination did, perhaps not the evaluation. And so this kid, I say here, just because someone got treatment does not mean that they did not get congenital syphilis. And this is a great case. I mean, everything worked. Mom got in. Mom got tested before delivery. She was treated well before delivery, had a great response to treatment. But the kid's physical examination was abnormal. And so because of that, the kid should have had a full evaluation and 10 days of therapy. The problem is this kid was sent home and sent for follow-up clinic. And so I got them in immediately, had them readmitted, and was noted to have neurosyphilis and got the appropriate treatment. So case 2. So on this one, mother was diagnosed at 10 weeks. Her RPR at 10 weeks was 1 to 32. So she got bicillin times 2. But then came back, and when they were checking her RPRs, it was then 1 to 32. So they said, oh no, maybe you have late latent. So they gave her again 3 doses this time around in second trimester, so well before delivery. Her RPR was 1 to 16. However, at delivery, the placenta, and here at Texas Children's, we get a lot of times we'll get placental histopathology, which is not, I understand that's not realistic everywhere in the state or in the world. But we got this back, and it came back saying that there was chorionic villi, delayed maturation, concerning for an infectious etiology, most concerning for congenital syphilis. But here's the trick. The infant was normal, and their RPR was a lot less than mom's. So the question here is that mom got 5 doses of bicillin, and she went from 1 to 32 down to 1 to 16. So how would you classify her response to therapy? Yep. Treatment failure. We'll give it a little bit of time to see if people are weighing in. And that's the thing, right? I agree. It sounds incredibly pedantic, but that's kind of syphilis. She was treated exactly how we should have treated. And the hard part is to say, well, why didn't her titer come all the way down? These titers were actually all at the same lab, so it's hard to argue against this being a lab variation. So, treatment failure adequately, partially, it's a hard question to answer. But the next one is okay, so we're saying maybe partially, maybe inadequate, this. Why do you think it remained elevated, though? I left something out that should have been a history in this mom, trying to see if anyone picks up on what it is, right? Reinfection. And this one's serifast. So for this one, the problem with being serifast would be that serifast would be defined as having an RPR that was less, 1 to 4 or less. So 1 to 16 actually is too high to be considered that. And so reinfection is a possibility, reinfection previously positive. And so a lot of this is absolutely true. But what people are getting at here is reinfection. So question I have is well, was your partner treated? And so we'll skip over this, but the reality of it is that the partner was not treated. And so I say this, that just because someone receives treatment does not mean that they were necessarily always treated. And so I know that sounds very odd to say, but again, someone could get treated and then get reinfected. So what happened was, in this case, her partner would not go and get tested and would not get treated, refused to do it. So the concern was she continuing to be reinfected because she remained sexually active with this partner? And so there was no initial evaluation that was performed, but given the placental findings, the recommendation was made that the infant have a full evaluation. The infant had an elevated protein on the CSF, a positive VDRL in the CSF, and received 10 days of therapy. Now, for the sake of time, I'll skip that one. It's a little bit more, not that the group can't handle nuance. I'd rather leave time for questions. So case 3, this is an older case, but saw the kid recently in clinic. And again, we're talking about congenital syphilis, so people realize this is congenital syphilis. But to give you an idea how these kids present, so this is a 3-month-old former 35-weeker who had in utero exposure to cocaine and was small for gestational age. At delivery, the newborn screen came back and said, oh, it looks like you have hyperphenylalaninemia. And so for individuals who aren't know what that is, essentially it's a condition where if you consume phenylalanine, it can actually have significant deleterious effects for your infant. However, was seen by genetics and said, this is just a carrier, you're not affected. So this child was being seen in the pediatrician for quite a bit of time and was having these off and on fevers. They couldn't really track it down, and then started to have lots of issues with poor weight gain and chronic non-bloody diarrhea. But then all of a sudden got a rash. And the rash started in the diaper area, but then spread to the arms and legs. And this is this rash shown exactly here in this picture. So got admitted to the hospital, was quite sick. And so was admitted, said she had severe malnutrition, severe dehydration. And the belief was that this dehydration and failure to thrive was because she was inappropriately mixing this strange Phoenix 1 formula for this hyperphenylalaninemia. And the plan was, well, we're just going to send you home to keep on gaining weight. Question I have is when you hear that story, and again, when you hear that story in the setting of your hearing about congenital syphilis, probably don't think congenital syphilis, duh. But what about the exam or the history makes you suspicious about just saying this is malnutrition because you're not mixing your formula? Anything there make you suspicious? And maybe there is nothing. Unexplained fevers. Yeah, that's true. They weren't ever documented, but I agree. In general, formula shouldn't necessarily give you a fever. I don't know. It would be a little odd one to me, but possibility, I'm open. So rash and fever, unexplained fevers. And then another one here, right? This was a small for gestational age baby who was born preterm, and the baby was exposed in utero exposure to cocaine. And so the question is, should someone who is an individual who is using cocaine, are they at higher risk for possibly having syphilis? Good question. So someone went, oh, heavens to Betsy, why don't we have any birth records on this child? And they said, we need to track down some birth records, and we don't know any maternal serologies. So they sent an RPR on this baby at 3 months of age, and it was 1 to 32. And so next question is, how did this happen? Like, here's the baby born. This baby was born in Texas. How in the world did this kid have syphilis and no one knew about it? Would you say that it's, providers managing the child at delivery just inadequately trained? Is it someone didn't know what was going on with the moms? Was the mom not tested? Was it a prozone? The Swiss cheese failure, which is, what happens whenever they put cheddar on your burger instead of Swiss. No, it's not. I used that at one meeting, and people are like, what is a Swiss cheese failure? They teach us that a lot in medical school. I guess it doesn't translate over. So provider training, absolutely. Mother not being tested, it's a possibility. So, I actually have an answer to this one, and it's oops. So if you notice here, at delivery, this mom was, remember, all mothers should be tested for syphilis, and her previous testing was reported as not done. Oops, errata, it was done. Mom was discharged prior to this actually being recorded as being done. So mom was sent home from the hospital at the time that they thought that they hadn't sent an RPR. Oops. But this RPR came back positive prior to the baby going home. When you looked at all of the records, what this was a mom who was positive at delivery and a baby who was exposed, and mom had had no treatment. But mom did go home with prenatal vitamins and ibuprofen. So this one is proven or highly probable because this kid had nothing, has an exam completely consistent with it. But what's interesting about this kid was that, the kid had some slight elevations in ASC and ALT, was slightly anemic, but actually the long bone films, spinal fluid, hearing tests, ophthalmologic exam, everything was normal in this kid, and got a 14-day course of therapy. And so I ended up seeing that child, and what I didn't have here, I'd taken the slides out for the sake of time, was this kid was down below 1 percentile when they arrived, like below 1 percentile for height, weight, or length, weight, and head circumference. And by the time that I was seeing them and following them up at 15 months, had completely recovered and was back up in the 65th, 75th percentile. And all that did that was, it wasn't the Phoenix formula. It was giving the kid 14 days of penicillin. So case 4, so this is a mother with prenatal care that started at 8 weeks. RPR at this visit was actually non-reactive. However, in the second trimester was noted to have a genital lesion, had no previous history of herpes, and so her provider did gonorrhea, chlamydia, and an HSV test, and it was negative. And so they said, negative, cool, but maybe you just have a GU staph infection. So gave amoxicillin. After the first dose of amoxicillin, broke out in a pruritic rash, had fever and a headache, and then the provider said, oh my gosh, I bet you have a penicillin allergy. We should, we should work on that. However, at the start of the third trimester, this rash on the palms and soles was worsening, and at delivery, the RPR was 1 to 1024. This individual did not have a repeat RPR done in the third trimester, just at the beginning and at the end. So, what do you think that first rash was? Someone comes in, has a GU rash, but then gets amoxicillin and explodes out with this crazy pruritic rash with a headache and a fever. And you think it was a drug reaction? Is it a chancre? Yeah. So one person's weighing in with chancre. Secondary stage of syphilis. Yeah. And I see the way in which I phrase this, that first rash, through the first rash is that the GU one that could be it. And drug reaction possibility, and this is what's hard, is it absolutely could be a drug reaction. How do you do secondary stage of syphilis? I like that. It's true. Palms and sole rash, which is a possibility. So, so fine. Like, okay, that's what we thought it was. But now if that baby is born in a mom who has a RPR of 1 to 1024, mom never had any treatment, what's the probability of congenital syphilis in this patient? Would you say it's unlikely, less likely, possible, proven, or highly probable? Or would you say you need more information in this scenario? And the reason why it's interesting walking through the cases is to give people an idea of what it's like when you're on the front lines dealing with this. If people are slow on doing it, that's completely fine. But what I would say is you need more information. The baby was born, but what does the baby look like? What was the baby's RPR? What was going on for this kid? So one thought, right, was this reaction, was this rash, the primary or secondary syphilis rash? It's a possibility. But another one has actually been very well described, which is called the Jarisch-Hersheimer reaction, which is individuals will get a large dose of an antibiotic that will treat syphilis, and they break out with fever, chills, headache, headache, tachycardia, and some exacerbation of skin lesions. And so the problem with this reaction is that you see it in individuals who maybe have syphilis and are getting treated, but it can mimic an allergy to a medication. As far as this kid, though, when the kid was born, had an elevated RPR of 1 to 32, but that was way less than what mother's was. The problem is, because this mom had no treatment, the kid had a full evaluation, and in the presence of the full evaluation, had elevated liver enzymes, had a positive VDRL from the spinal fluid, and so received 10 days of penicillin. And when I saw them in clinic at 2 months of age, their RPR had gone from 1 to 32 down to 1 to 2. And so then the last case here, before I leave time for some questions, was a mother had care starting at 8 weeks. 3 months prior to establishing this prenatal visit, she had had a stillbirth in the setting of a positive RPR. When she showed up in the hospital, she showed up, had a stillbirth. They screened her. Her RPR was 1 to 64 in the setting of having a full body rash. However, the mother, and not only was the mother told, this is also documented when I got the records, was told that they didn't feel that syphilis was the causative reason for the stillbirth because she had had a negative test at 8 weeks in that previous pregnancy. Therefore, probably syphilis was not the cause of this. However, this pregnancy, she received 3 doses of bicillin. And I point this out because when she had her stillbirth, they gave her a dose of ceftriaxone and told her to follow up with her primary provider. Problem is, she had syphilis and she was not appropriately treated immediately after the stillbirth. However, in this pregnancy, when she was seen, she got set up. Her RPR was 1 to 64, got 3 doses of bicillin, and came all the way down to 1 to 2. This infant at birth exam was unrevealing, and the baby's RPR was non-reactive. And so, question I have is, how could the mother have initially tested negative? This mom went, and again, everything is being done for these patients that's being recommended, at least in this woman's case. She was tested initially in pregnancy and was negative. And then before she should get her 3rd trimester, she had a stillbirth. So one person here is saying false negative. True. Yep. Primary stage, which is absolutely the case, right? Maybe she missed that. Prozone, exactly. Was this a case of prozone, or was it? And right, the problem with prozone is you have overwhelming infection and then you test negative. And maybe what it was that she never was infected. She got infected after she was pregnant, and that could have been contributing. Absolutely. All these are correct, appropriate answers. And so the question I have, though, is this mom was treated in pregnancy, had a good response to titers. The baby is well appearing, and the baby's RPR is low. Does the baby need an evaluation? And the reason why I put evaluation in quotes here, and people should be allowed to change their answer, not that I'm trying to telegraph it, is evaluation means you do a lumbar puncture, you do a CBC, you do a liver panel, you do all this stuff. So the question is do they need it? And in a way, I'm kind of glad that people are saying yes, 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 because the reality of it is, in this scenario, and here we'll skip over here. In this scenario, this kid would actually be considered less likely. And I hope this is confusing, because it is confusing. Because what did mom have? Mom had treatment early in pregnancy. RPR titers dropped from 1 to 64 to 1 to 64, all the way down to 1 to 4. So a huge drop. And the infant's RPR was not greater than mother's. Therefore, the infant examination, if it is normal, you do not have to do an evaluation, the lumbar puncture, the whole kit and caboodle. You don't have to in these scenarios. And so this child actually got a dose of bicillin. I've been following the kid up. I haven't updated this, but I saw the kid at 2, 4, and 6 months of age, and the RPR was non-reactive. So congenital syphilis in the newborn. No infant should be discharged without figuring out what mom's serologic status was. And if you can't figure out what mom's is, maybe mom's wasn't done, and then it needs to be done before that kid can go home. Also, any infants born to seropositive mothers, that means any mother with a history of syphilis, be it in this pregnancy or in the past, require careful examination, but not always evaluation. And what that means is you examine that baby. And if that baby comes out and they have a large liver and a rash all over their body, you're going to do the evaluation. But if you are lower risk and you have a normal examination, you can get away with not doing an evaluation. Also, a negative non-treponemal test does not rule out the possibility of congenital syphilis, but that is rare. And then finally, treponemal testing, maybe it's a little heavy-handed. It says has no role in management. Maybe it has a limited role. And I say this because the treponemal test, the TPPA, that's the confirmatory test. If a mother has syphilis, then her mom will have a positive TPPA, but you will detect that in an infant for up to 18 months. So if a baby is born and you send a treponemal test from that baby and it is positive, you would expect it to be positive if you knew that mother already had syphilis. And so unfortunately, I've seen a lot of people relying solely on that test to do a massive workup for a child, but it's just reflecting what mother had and not the fact that the infant actually has congenital syphilis. So my efforts, and then this should leave like 15 minutes for questions. And so I see this is a very, 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 very limited view of what I'm trying to do. And so what I noticed that a lot of these kids do not have a medical home, and they do not get, not only do they not get the recommended follow-up, they also do not get the recommended evaluation that occurs at delivery. In fact, when you look at like lack of follow-up and lack of this occurring, I saw about 35-40% in my own clinic with they have a visit and they do not show. Like, this is a documented, spoke on the phone, oh, you're going to show up Monday at 2 p.m. Cool, see you then. They do not show up 40% of the time. Other people who've been trying to track this have it around 40 to 50% of the time. And so what I've tried to do is actually normalize this evaluation within the electronic medical records. Whenever I see a kid, I'm collecting all of this information to make sure that what was done correctly. I'm grabbing, how was mom tested? What was her stage of treatment? When did she get treated? How many doses? Was the partner treated? You can see it all listed here. My hope is that by doing this across our huge medical system that we have at Texas Children's, we can hopefully understand natural epidemiology of congenital syphilis, but then also how do we prioritize treatment? How do we make sure that kids get followed up, they don't fall through the cracks, and then ebb this trend? And so despite our best intentions, rates are going up. I think a lot of people are like, well, I told them to follow up with their pediatrician and follow this up. Guys, that does not happen. They may follow up with the pediatrician, but most of the records that I get sent to me from the hospital have nothing there about it that would even allow you to figure out whether or not the child was appropriately evaluated. And so I'm here to help. I say, find me with questions related to syphilis. I get called from all over. Got, El Paso recently. I get called from Utah, North Carolina. So I'm here. Just when the questions arise, reach out. I'd love to help. And so, and before this last slide here, here's some old historical images of what was being fought with syphilis back in the 1930s and 1940s. Is this idea that there's so much shame, and these were posters that were commissioned by state health departments. And so some of these from Chicago, some from New York, this idea that false shame may destroy your future, have your blood tested, congenital syphilis is preventable if you get adequate treatment. And so this has been going on for a long time, and we're just fighting a battle that was waged about 80 years ago. And so with that, I'll leave it to say that, in that play that I mentioned that got bad reviews in New York, in the opening scene, Eugene Brieux, who wrote the play, said, I think syphilis will be considerably less serious when people dare to speak openly of a disease which is neither shameful nor a punishment, when those afflicted with it, knowing the miseries they can spread, are more aware of the duties they have towards others and towards themselves. And I point that out, that this was 40 years before we were ever using penicillin, truly had a good treatment for this infection, and a treatment that exists to this day. And so with that, I will stop sharing and would love to answer questions.
It's Elliot Davis from the health department, and I just got to jump in real quick and say you understood the assignment, sir. Thank you so very much for this. It is clear your expertise is evident in your delivery, and I not only appreciate the history of it, but being from a policy social work background, I appreciate you going into not just the policy development around it and implications, but also the stigma that's woven throughout there, because that's something we all should keep in mind. So thank you so very much, Dr. O'Shea.
Oh, you're very welcome. And a lot of people think the history is esoteric, but it's been, I have found more often than not, you'll have an individual who you're talking with them in clinic and they just seem like they're frustrated with it or they're confused. And, I legitimately have pulled up lines from that play. There was a line that says, syphilis is a disease like all other diseases, and it's just a misfortune, but there should be no shame in being misfortunate. And it's surprising how many people that statement resonates with, and it's 120 years old, that perspective about something, so thank you. Any other questions from anyone about, good Lord, why don't we have a better test? Or, let's see here. Let's see.
There is one in the chat you may be seeing.
Yeah. So is there a way to pair newborn with other reportable diseases like perinatal Hep B? Okay, so Aaron, that's a really good question. And, right, I'll say, if there's one thing that we do really well, we specialize in certain things. And so you're like, oh, one clinic to rule them all. The reality, though, is for something like Hep B, and it's great you bring up this question. I actually saw a kid just the other day, and part of the referral was, congenital syphilis and Hep B. The reality of it is, in getting kids care, I think for any children, my belief is that you should be seen by the person who is best trained to answer that question. And here, actually, at Texas Children's, when individuals have Hep B or Hep C perinatal exposures, they're actually followed by our hepatology group. And so whenever I see them, I actually put in a referral and get them directed in that way. And it's more because, these can have long-term follow-up plans, long-term follow-up testing. And it's just, part of his, maybe I would say, maybe it's my own lack in an area, but here, at least within our system, those are managed by the hepatologist. So when it happens, I get them there. Had one with Hep C recently, get them there. And we've actually had a few who have been both syphilis and HIV, and we've worked together with our HIV colleagues here in retrovirology as well. So I hope that answers your question, Aaron. And another thing I'll just say, maybe while people are thinking of questions or not, I've actually had now, I believe, 3 individuals who've been identified from the health department who have reached out directly to say, hey, we've got questions, and they've called, we discussed it, which is cool. Another one was making referrals actually for individuals to be seen and to be followed up in our clinic. And, this can be done through, in a way, it can be done through a web portal. You don't actually have to have Epic or this. You can go online and you just Google refer Texas Children's infectious disease, and it'll pop up a red cap form if people have questions, or it's like, I'm worried about this individual, I'm not sure that they were treated or evaluated appropriately, and actually have caught a few. But one of the main things I stress to everyone about this is that if all parties involved have an understanding of the importance of longitudinal evaluation, there's nothing, in my opinion, there's nothing more valuable than that. I had a mother today who is so afraid, like, oh my gosh, was the wrong thing done at birth? And I was like, if it was or it wasn't, we have a plan for testing. We're going to get you testing. We're going to get you treatment. We're going to do all of this, and we're going to follow. And her level of, it wasn't concerned, but she was freaking out. And it went from up here and came all the way down because it was a cohesive plan that she understood the parameters of why we needed to keep on following up these kids. Because it's not just one follow-up visit. The recommendations are to follow up through at least 6 months of age, because you're trying to make sure that the individual does not have incubating syphilis, particularly in a scenario where a child did not receive treatment at birth. And I will add my email here in the chat. I shouldn't be that hard to find, but in case anyone, yeah. And I think, let's see here. And I'll say, I didn't go over the Bicillin LA product shortage. Chrissy, I'm not sure if anyone else here can speak to it. What I can say, though, is that there has been talk that there is a plan to retrain an entire workforce for the production of Bicillin. One of the issues that was brought up was that certain places can reconstitute. Some places can actually reconstitute the Bicillin. So, for example, here at Texas Children's, when we have a kid in the NICU, we do not have to waste an entire vial on a newborn. In fact, we have a choice to treat one adolescent, or we can treat one adolescent or like 60 infants, because we can reconstitute it. And so I know that this is an issue, but from way higher level talks than me, there's a big talk that hopefully by Q3 or Q4 of this year, this idea and concern about shortages should start going away. And the CDC actually did recommend that if there are questions or concerns from large entity requests towards Bicillin, their words, not mine, they have stockpiles. And so to reach out directly to the CDC, and there's actually a drug shortage CDC site that people can request information from.
I was going to jump. Oh, go ahead.
Oh, Sorry, I just wanted to say, I think my issue with the whole thing with syphilis, I work at the Dallas County Health Department, is the really the purpose of the testing. Because the testing is so old, it's like almost seems irrelevant at some point because there are so many factors that CDC doesn't acknowledge are issues with the test. Like if your titer is supposed to go down, how long is it supposed to take? You know, they say like a year it should be going down, and then like within 5 years it should go to 0, but why? You know, and then you'll see people who they do go down, but they don't go to 1 to 4. And what's the difference between 1 to 4 and 1 to 8?
Yep.
I think that can make it really hard for patients and for the medical, just like everyone in medical, to really make it clear to patients and to ourselves what we're even really accomplishing when the test isn't going to be definitively telling you, did we really get rid of it or not?
Exactly, Trudy. And this is why, right, education about the test. And again, if you understand that a test has problems, I think that's a lot more valuable than saying this test is perfect. So for example, I had an individual who was being followed within our system, and within our system they had years of having had treatment, and their RPR was 1 to 2. So they were serifast. But then all of a sudden, someone sent the person to go get a lab done at Quest, and it was 1 to 8. And then they freaked out, and then they sent them back here, and it was repeated. It was 1 to 2. So people went, oh my gosh, got reinfected. I'm like, no, it's a different lab. So many of these things, right? These fractured healthcare systems where people are bouncing around, going from one lab. It is hard. You can have differences. I had a difference in a kid who was, I think the kid was about 6 months of age. I had differences between Quest and our own lab of a 1 to 2 to 1 to 16 on the same day. That's a problem. And so, yes, right. Everyone is trying to make a new test, Trudy, and this is where everything is going. But if you think about it, what makes this really hard is whenever you develop a test, you want to develop a therapeutic, you want to develop a test towards something. What organism are you going to test against? And this is what pragmatically is really hard. The way in which you traditionally grow Treponema pallidum is you take infected organisms from a lesion, and then you find pregnant rabbits and you infect the placentas of the rabbits and you try to get it going. You cannot cultivate this on media. So it's really hard when you can't cultivate it to then test for it. And not only that, we reached out for a project to try to get Treponema pallidum from the CDC, and they're like, we're out. We don't have any more. So when you can't grow something, how do you then make a test for it? And then you end up saying, well, I'm going to make a new test and see how it works in reality. But how long do you think it's going to take to test to make sure that the new test you're using works when practically applied on a population? Sounds like research, and it is. And so this is what makes it so hard, Trudy. It really is. And so people are pushing for it, but even these PCRs are not great. And so, Trudy, does that help a little bit? Like, because everyone is pushing towards this, and there was a project that someone reached out about wanting to do this and looking for a new diagnostic, and we're like, we need to get a hold of some syphilis, and they're like, yeah, we don't have any. There is none.
Yeah, that does help. It's nice to just talk to another, provider, because I just hear a lot of people panicking about syphilis, and I think, well, honestly, this is what you get because you're not hitting it from the source. Like, we spend so much money on HIV, totally get it. On the other hand, you're really stealing away from other issues like syphilis, and then being surprised when you get a flare up, and it's a very reactive approach. I'm Black, so I guess maybe I have another concern because, I'm part of the Black community, and I get it for our people since we tend to test positive more often. Yeah. It's like, it's not even a theoretical of like, oh, we'll get there one day. It's like, yeah, but you really make it hard for people if your test isn't making any kind of sense. And even as a nurse, I'm not able to understand. I'm also not super hopeful about what are we really accomplishing, because like you said, I've heard that it's very hard to grow it, but I'm like, HIV is extremely tricky. And yet we have a NAT. We have a NAT for chlamydia, gonorrhea, and HIV, but we don't have a NAT for syphilis. It just seems like
And
that's kind of disappointing.
And what I'll say is that there are and the other one is that there are attempts towards that, right? There are attempts and there are movements, and one of the big ones, right? And one of the hard parts here is that you're trying to develop, and Trudy, I this is not like a believe me. No, I agree with you. I think the hard part is when you're trying to test the efficacy of a novel diagnostic test, right? And you have something like a single dose of bicillin may work, right? In a developing child, how do you know that your treatment worked? Is it that they look good at 1 month of age, 3 months of age, 6 months of age? And so a pushback is a lot of people say, well, if your new test is good, you need to show that if you roll out this new test, long term, you're going to be fine. So there are tests in development, but they may take, you may have to say, I'm not gonna know whether or not it was a good predictor for the next 12 years. And so that's why they're doing them. They are doing them now. But your words are hitting home. You're absolutely right. And it's hard when you can't grow it. It's hard when we think that our tests and our tools are terrible. But I do want to point out that the rates that we have now are worse than they were in the early 50s. We had the same tests and the same treatment in the early 50s. So why aren't they working?
Well, I think,
I'm not saying don't make new things. I'm saying that there are a lot of there's a lot of this approach to how this is not just, it's not a therapeutic, it's not a diagnostic, it's not a this, it's so many things. And that's why I'm saying expand the tent, allow anyone to come into the space to try to help. If it's in policy, cool, go for it. If it's in education, cool, go for it. Treatment, cool, go for it. Expand the tent to try to get help.
Because I can't wrap my head around the RPR now that the CDC decided they want people to go to 0 within 5 years or something. Seems pretty arbitrary, but I guess I get it. It's showing there's some kind of immune response, but even without treatment, supposedly the titer, it can go down. So what is it even signifying if you get treated and then the titer has to go down fourfold, which again, is still kind of arbitrary. But if it goes down to like 1, it goes from a 1 to 64 to a 1 to 2 in 1 year, that's great. But what if it doesn't go all the way to 0 in 5 years? Why is that then considered that you still have it? Or that seems odd.
Yeah, exactly. And so what the RPR, and I had that slide that was pulled up, that what the RPR is it is and I often tell people that in a way the RPR is just a quick version of a test developed in 1906. And what it is it's detecting lecithin, cardiolipin. It's detecting essentially proteins, lipoproteins that are produced because syphilis can affect blood vessels, and so someone picked it up, and that's what it's detecting. But it's also non-specific, and this is why if you have malaria, you can have an elevated RPR. If you have hepatitis B, you can have an elevated RPR. If you get, and no joke, like if you get a vaccine and then a day or two later, there have been reports of individuals popping a positive RPR. And that's why it is a sensitive but non-specific test. But in that question of like, what are we doing? How do we track this? I will point towards the fact that I'm not throwing shade at the CDC, but it's the reality that we live at, that the CDC STI guidelines say nearly all the recommendations for treatment and management of syphilis are based on the opinions of persons knowledgeable about STDs and are reinforced by case series and clinical trials. But the reality of it is that people have become accustomed to these tools. And so you used to have a generation of providers who kind of knew the tools that they were using. You can go to Home Depot and get that beautiful looking hammer, but maybe you're a carpenter and you love your old hammer because you knew how it worked. But the reality is the workforce now has trained and never seen a case of congenital syphilis. And I don't know what to use. And so this is where I think education, but I completely hear your point, right? That people are starting to freak out about it, but running around freaking out about it is not necessarily always the best approach, because then it shows also that and you're right, like, what are we doing? Why aren't we working on more? And there is a push, right? You can actually get a treponema pallidum PCR done at the Mayo Clinic. You can have one done at the CDC, but since they aren't commercially available, good luck getting them done. I spoke with a group in Malawi and they were reaching out, and their biggest issue was that in order to get an RPR done, they had to pay for it out of their pocket, and it took a week for it to come back in RPR, right? And so every place is different. So, sometimes recommending a PCR, at least until we've proven that it is valuable in making a difference, is it's good. But I think that if we turn our attentions towards epidemiology, we turn our attention to asking a simple question: was your partner treated? No one documents this in the chart whatsoever. No one does this.
Yeah, that's true. That's a good point.
And those are risk factors. And so this is why I'm trying to chip away at it. But also understanding that the true solution is just a little bit of penicillin. And so I was glad to hear that Pfizer appears to be ramping up their efforts, because if we have bicillin, I think we have an answer. We have a way to get back. If we have bicillin and we have loads of it, it's going to make a lot of things easy, because with doxycycline, it should work. But they do say in the guidelines, if you treat with doxycycline, you really need to make sure that those titers come down, because you need to. Because I have allergies all the time in Houston. Do you think I take an allergy pill every single day? I forget. I forget to do it. So if you're supposed to take a month of doxy, if you think that everyone's going to be 100% compliant, and they are not, I've got a bridge to sell you, because they're not going to. It just doesn't happen. But it's a lot easier when it's a single dose.
That's true. But how do you determine, because I know it's different with the babies and I'm treating adults, but what is your definitive determination that the medicine worked? Because I get what you mean about penicillin, but on the other hand, it's hard, because even with penicillin, the RPR doesn't always go to 0. Some people stay at like a 1 to 2 for it seems like the rest of their life. Great
question. So in an infant treated at birth, their RPR should be non-reactive at 6 months of age. And yes. So I have yet to see a single child treated so far, and this is getting close to 200 kids. I've yet to see a single kid treated at birth whose RPR was positive at 6 months. Now, treated in the antenatal period, like that one kid, that case 3, that child who had that rash, that kid remained positive at 15 months of age and actually got readmitted, retreated, because those are the recommendations that if you do not serorevert as an infant, there is still concern that maybe you needed more treatment. So that child actually got readmitted and retreated. But in a child, that's what you're looking for. But Trudy, the point that I tell every family is the how do these kids do? They do okay. And I put that in air quotes because they do okay is on the basis of follow-up studies that went to 12 months of age.
Yeah.
What about the follow-up study that went to 6 years of age? Doesn't exist. What about 18 months of age? Doesn't exist. And so that's why what I'm hopeful in setting up this clinic and seeing these kids is that while I will see them through 6 months of age, I have an idea of case ascertainment. I will be able to say, for this baby, their mom was 1 to 16, went to 1 to 4. Mom got 3 doses of bicillin. The baby got 1 dose of bicillin. They did this, and at 6 months, this is how they looked. Now, as they interface with our healthcare system, I hope to passively pick up information, because it's expensive to come see me. But if this kid at 4 years of age breaks their foot and they show up in our emergency room, we will get information like, hey, what's going on developmentally? How are you? Oh, you're developmentally an 18-month-old. That's a problem. We'll pick up that information. And so I completely agree. But that's the hope now, that when there are a lot of kids who are being affected by this, helping educate the family to say, look, personal experience says these kids are okay. But remember that if anything comes up or you have any questions, we're here. Reach back out. We can help you access care. Because if you truly do have deficits because of a congenital infection, you are protected in getting sort of supplementary services for that congenital infection.
Oh, okay. Yeah, that makes a lot of sense, because like you said, like even though syphilis is super old, the issue is that our getting a handle on it is really new. I mean, 100 years is not that long when you would think about it. Yeah. So that's great. Yeah, that you're thinking of like, well, we just need to do more observation, which is a hard but important thing to do. And that's more what I believe in medicine. It shouldn't just be based on tests. It should be looking at them, the whole person. Yeah.
And you've got it. And to give you an idea, like, why aren't we doing more of this? Because if you want to do the developmental test for these kids, right, the gold standard to say that they're developmentally cool, about $5,000. So how many tests are you going to have to do? You're going to have to do Well, at least 100. Okay, so $500,000. When are you going to do this test? One time?
Yeah.
No, let's do it every year. Okay, do it every year for 10 years. All right, now you're at $5 million. And like you said, Trudy, everyone's just waiting to throw money at this problem. Not really. So there's it's a work in progress, and people are trying to ramp up to do this. But these long-term observational studies are just harder to do. But my mentor actually at Texas Children's did this for congenital CMV and did this in the 80s and is still doing it today. The difference is for congenital CMV, it will probably always be a problem. But for congenital syphilis, hopefully we can get ahead of this and put me out of a job.
Oh,
not really
yeah,
that
that
it's
sounds
like
great.
not really that's like a job, but at least turn these numbers down.
For sure. My last question, and I'll give it to other people. To understand the RPR, that's what I have to use to determine if someone's been cured and if they've been reinfected. But I'm getting lost now since the CDC decided you should get to 0 within 5 years or something. Your description makes sense. It's a protein. It's a sign of like inflammation. It almost sounds like it's like the CRP or whatever, or C-reactive protein in a way. Is that kind of how to think of it? Because like how does it actually correlate with like the idea that the medicine killed this creature called syphilis?
Yeah, good. It's a good question. And to be honest, you say I was just on a meeting and just talked about these like how to interpret the RPR with someone who's at the CDC specifically on congenital syphilis, and this did not come up. But I guarantee you this: I'm going to be texting him when I get off this call and be like, "What's this you say?" And again, I think some of it is on the basis. What makes it really, really hard is when you look at these long-term follow-up studies, they have been limited. And so maybe the point is that they're trying to get this number down to 0. There is evidence. There was a paper in 2017 that showed that you should sero-revert and become negative, but this is also a subjective test. I used to, and no joke, when I used to do this lecture, I would have RPR cards up, and I'd be like, all right, guys, what's the RPR? And I would ask people like, click where it was that they thought the RPR was. And the reason I got rid of the test is because I never got it right. I would always get it wrong. And so, you remove the question, you don't want to look like a complete fool, but it's a subjective test. It makes it hard. And so I don't know if this is because they're working on newer assays that are going to be a little bit more standardized. But I can say there have been a lot of people that I have seen who have evidence of treatment within our own system, and they remain 1 to 1, 1 to 2, and they fluctuate between there. So this idea of getting rid of what is truly a serifast state, I think that's going to be very curious to see that one roll out, because in my opinion, I think that we have been doing things to make management in syphilis more comfortable, and not necessarily always on the basis of where the evidence pointed. One of these is, there was a recommendation recently for adults, or do you take care of adults, which was, do you need to repeat the tap on an individual who was treated for neurosyphilis? And it used to be that if an individual had neurosyphilis, what you would do is you would repeat the tap at 6 months, and that's a lumbar puncture. It's no small feat. I don't want to make that like say, oh, it's just an LP, don't worry about it. It's a procedure. But what they did was they actually studied this, and they said, look, if an individual's RPR comes down, and it comes down enough, the chances of them having neurosyphilis that's untreated it's really unlikely. So that's what everyone said. Then you go and you pull up the paper, and the authors say, however, doing this, 12 to 37% will be misclassified as having experienced success. What?
Yeah.
What? Hold on. And again, right, I'm not saying everyone rush off and do lumbar punctures, right? I believe the authors. I believe people above me who are saying that this is the interpretation. In fact, there's someone here at Baylor who is like a guru of syphilis, and he is like, in his experience, this is the thing, in his experience, in our experience, in this. And I'm a huge advocate of, well, then prove it. And so that's what I'm just trying to do. So.
Oh, okay. Yay. Thank you. That's great.
All righty.
Well, and Trudy, those were excellent questions, and it is a pleasure to virtually meet you. We need to get to know each other more. I know your hepatitis
Thanks.
partners at the county.
Oh, cool.
And Dr. Roche, you can tell, you don't have to convince me how precious this information is. You can tell by how many people are still hanging on almost 2 hours later, how appreciated it is. So I don't want to cut this short, but I want to respect your time. So if we need to look at another solution, if you guys want to keep going, I'm here for it. Otherwise, if you want to like have folks email me and we can get questions together.
I was going to say, I think I am good through until 2, because at 2, I have a congenital syphilis patient coming to see me.
Okay.
So,
Okay,
so
we'll
if people
leave
have
it going.
questions, cool. If not, again, I put in the chat, I put my email address, and I'm always down for fielding questions. So,
can you hear me?
yeah.
I had a question. My name's Dr. Hunter Hamill. About 20 years ago, we looked at the case of congenital syphilis. They all had one thing in common. They all had been in the ER at some place pregnant, but were never tested.
You got it.
And it's been suggested at that time that if a pregnant woman shows up one of these scenarios, they get tested. That hasn't been done yet, has it?
So the Texas law mandates that if there is the first encounter that a provider has with a pregnant individual, an RPR should be done if it has not been verified. So what that means is for example, we just had one recently. We had a kid show up in our emergency room who was pregnant, and she showed up and they diagnosed her with pregnancy, and we sent an RPR. We did it.
Which
because that was
normally
her first
would
visit.
not be done. Normally they don't do it because they say the ER doesn't have time to follow up.
Oh, we don't have it, or we don't do this, or but I mean, she's pregnant, so someone else definitely did it. But one thing that my mentors here often told me, I forget who it was. I don't know if it was Gail or some of the more sage PDID doctors, is go find out for yourself, right? If a pregnant woman comes in and you're seeing them, and you're like, well, someone definitely did an RPR. Well, if they definitely did, it should be really easy to find it. And so this is where, my interest in health informatics does weigh in, which is as we begin to have more shared data systems, because what will not be reported to the health department is a negative RPR, right? A positive one sure should be. It should go that way. And so, as more and more, and here, sitting in my the ivory tower that I sit in, I have the ability to see. I can see Harris Health. I can see Kelsey-Seybold. I can see HCAs. I can see a lot of places, right, by privy of where I sit. So I can tell whenever someone shows up, did they have previous positive testing? But sometimes providers don't realize that you can find this information within shared electronic health records. And so
but if they haven't done the test.
Yeah, and if they haven't, exactly. If they haven't,
I think ERs are not notoriously doing tests. Another question.
Yes, sir.
Do you think the PrEP program without condoms has spread syphilis? HIV PrEP, they've de-emphasized condoms.
No, I think that's a hard one to field. I think a hard thing for me, one thing that I think makes this very difficult is the idea that the minute that someone gets exposed, that may be 3 months before they have any symptoms. And so it's going to make contact tracing very difficult. It's not one of these, that someone was like, oh, if we just had real-time data analytics. I'm like, if you have real-time data, if I go and I get syphilis right now, I won't test positive for it for probably the 8 weeks at a minimum, and it may not have any symptoms for a couple of months. And I think that's really what leads to it. That's one thing that's leading to it, is just this. It is still stigmatized. People do not talk about it. And also, like you were saying before, I think that, I'll find one more. I was debating someone up in Toronto about this, and here was a paper by Dr. Wilkinson in 1971. Though historically recognized as the great mimic, a new generation of physicians, especially pediatricians, has been trained without ever having seen a case of syphilis. 1971. So where do you think we are now? And I agree. I think that most people haven't seen it, are ill-equipped, and are looking for something else. A fascinoma, that infant with the horrible rash, that was failure to thrive. It was acrodermatitis enteropathica. No, it was just syphilis. It was. So I think that we do sometimes look other ways, and that is that sort of cognitive dissonance is what makes it hard.
Thank you.
Mm-hmm.
I'm from the generation where when in doubt, you order syphilis.
Yeah, that's what I was joking with my residents. We were going around and they were like, well, the person had congestion. I'm like, it's syphilis. And they're like, they have a rash. It's syphilis. And they kind of made a joke. They're like, Dr. Roche, do you want to send a test for syphilis? And I'm like, no, they're like 2 years old. Don't. But I think I made the point across. But yeah, the great imitator. Thank you.
Thank you.
All righty, everyone. There are no other questions. Next time, and if you have kids that you think need to be seen or evaluated, you can always send them my way, or you can always give me a call, and we can chat about it.
Dr. Roche, you have been absolutely fabulous, sir, and your daily work, and especially in this. I very much appreciate it.
All righty. Well, thank you so much for letting me come and talk. I'm glad people enjoyed it.
Thank you, and thank you, everybody, for attending. We'll get slides out ASAP.
All right. Bye-bye.
Bye. Have a good week.